Hello students, welcome to the session. I am Dr. Ravina Reddy, your medicine faculty at Medico. Welcome to the session of test and discussion. Today we are doing medicine. So what exactly we are doing in this test and discussion, how you can incorporate this into your studying schedule is, so medicine, not only medicine, any subject, you can read it in two ways. Especially medicine, it's a vast subject and most of you have a fear that you could not complete it in time, right? So first thing is you read and do questions. And the second thing is you do the questions and then read. So this both ways you can do. Now we are doing this way. We are taking up the question from each. Sorry for the disturbance. So we will take each question from each important topic of the medicine and we will discuss the question. We will discuss both concept and how to apply it. So these days exams are not factual. Until 2020 your NEET PG questions are all clinical, but recently the pattern has changed to factual, but your recent exam is clinical based. You should know how to apply this. So in exam, how will you apply? So to apply, you need to pick up the key points in the question. So a question, you need to pick up the key points. So to pick up the keywords, it's not that easy to pick up a keyword. You should know the integration. You should be able to connect all the subjects from your anatomy to your final year, all the subjects. If you connect only, then you can pick up the key points and you can connect and get the answer. First thing is you should learn the integration. If you keep on reading anatomy, physiology, biochemistry separately, you keep on reading, your integration will be only to a level. Only if you revise twice, you will get that integration, that too to a level. But only by doing the MCQs, you can improve your integration. And one more thing for pick upping the keywords, you should have a presence of mind in the exam. That is the reason you should have a good sleep before the exam. So, to pick up a keyword, you need that integration and presence of mind in the exam. So, it's just simple. Pick up the keywords, pick up the answer. Pick up the keywords, connect and pick the answer. So, your exam is in parts, right? You don't have a time or chance to go back and look at the answer and correct it. Sometimes by doing the 100th question, you will be like, okay, first question, this could be the answer, but you don't have the chance now. So 40 questions, you should answer it and go to the next session, right? So you will be like shooting the questions, and if you shoot it, it's fine. If it's not, then it's wrong. So the presence of mind and the integration, that is what you should develop. For that, you should be doing more questions and read the concept. Just by solving the question and looking at the answer, that is not enough. You should solve the questions and discuss it. That is what we are doing in this session. So how are we going with this session? It's not system wise, it's just jumbled, because in exam you should learn from jumbling one topic to other topic. In exam, your mind should be prepared from jumbling from one topic to other topic, right? So the same thing we are doing here. Let's start with our first question. So the same thing we'll do. We'll pick up the key points, we'll try to integrate it with the presence of mind, and we'll get the answer. After that, we will learn or discuss the important topics related to that, important things related to that topic, okay? So I'll be highlighting the key points. So in this question, it is a 65-year-old male. He came to the clinic with complaints of intermittent claudication. So his complaints are claudication, and he's describing that as a cramping pain in his calf. So that is what is claudication. And on examination, the pulses in his right leg are weak and a ankle brachial index is 0.6. These many keywords he gave you. That there is claudication, weak pulses, ankle brachial index is low. That means there is a peripheral vascular disease. So based on these key points, I came to the diagnosis of peripheral vascular disease. So just diagnosing is not enough. He's asking a question on peripheral vascular disease. What type of arterial pulse abnormality you see in peripheral vascular disease? What is a peripheral vascular disease? To your peripheral vasculature, when there is decreased blood supply, you call it as a peripheral vascular disease. So to a limb, there is decreased blood supply. So what will be the pulse? Just think. The pulse will be weak or absent or low volume pulse. Absent or diminished pulse. That is what is the answer. So coming to other options. Pulsus paradoxus. Pulsus paradoxus means it's not a pulse, it's not a paradoxical phenomena, it's an exaggerated BP phenomena. Normally on inspiration, your systolic blood pressure should decrease by 9 mm of Hg, but if it's decreasing more than 9 mm of Hg, you call it as pulsus paradoxus. And that is not what you see in peripheral vascular disease. What is pulsus bisferens? It is two-peaked pulse, two peaks in the systole. That is you see in severe aortic regurgitation with mild aortic stenosis and hypertrophic obstructive cardiomyopathy. And pulsus parvus et tardus, it's a short peaking and late peaking pulse. You see that in severe AS. Pulsus paradoxus you will be seeing in pneumothorax, and we'll see the causes. Just reading the causes of pulsus paradoxus won't help. First you should know why that phenomenon is occurring, only then you will know the causes. We'll discuss that in detail. Pulsus bisferens is seen in severe AR with mild AS and hypertrophic obstructive cardiomyopathy. Pulsus bisferens, the name itself is saying bi. There are two peaks in the systole. Bisferens, by S, two peaks in the systole. Pulsus parvus et tardus is a short peaking and late peaking pulse, and it's seen in severe aortic stenosis. And absence or diminished pulse are seen in peripheral vascular disease. And the cause of that peripheral vascular disease could be anything. It can be a thrombus, it can be an emboli, or it can be a vasculitis, which is involving the medial vessels, or it can be traumatic, anything. So that is the answer. So now we have discussed about the question. There are few important things you should note down in this question and you can learn. What are those things? So what is claudication? What is claudication pain? How does the patient explain that? It is a crampy, fatigue pain in the bulk of muscle. So wherever there is muscle bulk, for suppose there is decreased blood supply in the lower limb, you get the pain in the thigh and in the calf. So wherever there is bulk of muscle, you will get the pain there. That is claudication pain. And if you observe here, that pain is occurring after walking a short distance. So at rest, while sitting, there is no pain. He got up and started walking a distance, only then he got that pain. But even with pain, he could not move further, and that pain is relieved with rest. So he started walking, there is a pain, so he stopped because of that pain. So which grade of claudication it is and what is that grading called? It is Boyd's classification. So Boyd's classification, it's for grading of your claudication pain. So how do you grade it? So a person is having claudication pain. So when does this claudication pain comes? When he is walking. So he's walking, he's having claudication pain, but still he chooses to walk. After walking some time, the pain disappears. That is grade 1. No, the pain did not disappear. But with pain, somehow he manages to walk. That is grade 2. No, the pain did not disappear, and because of the pain, he need to stop. That is grade 3. So claudication pain, grade 1, he continues to walk, pain disappears. Grade 2, he continues to walk with pain. Grade 3, because of pain, he has to take rest. Here, because of pain, he has to take rest. It is Boyd's grade 3 claudication pain. I'm clear, right? Next thing is weak pulses. You know how to look at the pulses against the bony prominences, and you will compare with your pulse or the pulse of the opposite side to know whether it's low volume pulse or normal volume pulse. Now coming to ankle brachial index. What is ankle brachial index? You should know how exactly to measure this, because nowadays the questions are clinical, they can ask you. So what is this ankle brachial index? It is the difference of systolic blood pressures at the ankle and at the arm. So systolic blood pressure at the ankle by systolic blood pressure at the arm. I cannot say simply systolic blood pressure. So where are you tying that cuff? BP cuff, where are you tying? So BP cuff you can tie to the cuff, and you can measure the pulse at dorsalis pedis or posterior tibial artery. And coming to systolic blood pressure at the arm, you have to measure it at the radial or ulnar artery. Radial is comfortable. Okay, so systolic blood pressure of the ankle is the involved ankle, and brachial means, for suppose I'm measuring the systolic blood pressure of right ankle. Here in the question, in this case, the problem is in the right leg, right? So I have measured the BP in the right ankle. Which brachial pressure should I take, right or left? Because it's the right ankle, you are going to take the right, or you are going to take the highest of both. Here comes the difference. You have to measure the systolic blood pressure at the both radial arteries, and whichever is highest, you have to take that. That is why you should be more specific. So precision is more important for your shooting. You have to shoot in the shortest time. So you have to be more precise while reading. So it is highest systolic blood pressure at the rate of involved ankle by highest of the both brachial systolic blood pressures. Among right and left, whichever is the highest, I will take that. Excuse me. So this is what is ankle brachial index. What is the normal ankle brachial index? It is 0.9 to 1.3. So in this given question, the ankle brachial index is 0.6, right? So it's low. If it is less than 0.9, it means that limb is having a peripheral vascular disease. And if it is 0.5 to 0.9 means that patient will have claudication pain. So less than 0.9, I'm dividing. And if it's less than 0.5, he'll have ischemic nerve pain. It's the pain of dying nerves. So your caudation pain is at the muscle mass and your ischemic nerve pain is at the most distal part of that limb. You got me right? And this claudication pain is related to your movement, motility or usage of that limb, whereas ischemic nerve pain is occurring at rest. So that is the difference between claudication pain and ischemic nerve pain. So ischemic nerve pain is developing means more chances that that limb will go into gangrene. So that's the most severe condition. So these are the things you are going to learn in the question. So now you know what is claudication, what is the classification, how are you examining a case of peripheral vascular disease, and what are the pulses you see in peripheral vascular disease. And you also know the other pulses. Let's see the diagrams of the pulses because in exam they can ask you the picture based type of pulse identification. So this is the normal pulse wavegram. So this is a waveform of a normal pulse in which you will be having a systolic upstroke, systolic downstroke, diastolic downstroke and a diastolic notch. So this is a dicrotic notch in the pulse waveform and it's going to correlate with your S2. So after dicrotic notch, whatever it is diastole. So before that notch, whatever it is systole. So why this notch? It's because of the closure of aortic valve. Aortic valve closure, aortic and pulmonary valve closure is nothing but S2, right? It's very simple. Pulse means, what is pulse? Because of the LV contraction, you get a waveform in the arteries and that is what you will be seeing as pulse. So S2 is because of the closure of aortic and pulmonary valves. So pulse is because of the left side. So it's aortic valve. Very simple. You don't need to confuse in the exam. Coming to different forms of pulses. In the question we have already discussed what is pulsus bisferens. Pulsus bisferens means the name itself is saying bis. Bi-peaked pulse in the systole. There is one more pulse called pulsus dicroticus. That is also two-peak pulse but one peak in systole and one peak in diastole. See, pulsus dicroticus, the name itself is saying. Dicrotic, in the name there is D. So, two peaks, one peak will go in the diastole. Whereas pulsus bisferens, two peaks in the systole. You don't need to confuse. So as an undergraduate, I also used to confuse between bisferens and dicrotic pulse. So now it's clear, I think. So as we spoke, this is the dicrotic notch. Whatever is before the dicrotic notch is the systole. So in systole, you are getting two peaks. And you see that in severe aortic regurgitation with mild AS. I also told you in hypertrophic obstructive cardiomyopathy also you will be seeing the same type of pulse. But in HOCM, the first peak will be like a spike and the second peak will be like a dome. So spike and dome pulse is also a type of pulsus bisferens and seen in hypertrophic obstructive cardiomyopathy. Don't get confused. And your dicrotic pulse, you see where there is severe vasodilatation, especially in your septic shock and in your early heart failures. In early heart failures, for compensation, more of nitric oxide will be released. That is why there is more vasodilatation. So where do you see dicrotic pulse? Wherever there is severe vasodilation, you can see the dicrotic pulse, especially in the septic shock and early heart failure. So until here, it's fine, right? So in this question, not only peripheral vascular disease, we have discussed almost in details about pulse. And in your CVS, your pulse and JVP are the most important things. Not only the clinical examination has importance, in exam also examiner is giving much importance to pulse and JVP. Whether it's NEET PG or whether it's INI-CET, one question from pulse and JVP is for sure, and you cannot by heart pulse and JVP, you have to understand it. Okay, coming to the next question. So the same thing, we'll highlight the keywords, get a diagnosis, we'll discuss, and we'll get the answer. So that one step you have to do in the exam. So other things we'll discuss about those, because you should be able to answer other question of the same type and you should know the concept, right? So this question is a 55-year-old male and he's having a history of COPD, chronic obstructive pulmonary disease. Now he has come to emergency with worsening shortness of breath and swelling of both legs. So a case of COPD with shortness of breath and pedal edema, the first thing I will be thinking of is the right heart failure, because chronic lung disease can cause cor pulmonale, right heart disease. So the first thing I'll be thinking about that. But there can be any cause of right heart failure, not only COPD, sometimes any valvular diseases, left heart failure, or pulmonary thromboembolism. All these things can cause right heart failure. So you should also exclude other causes of right heart failure. But your first differential will be cor pulmonale. So after seeing these 4-5 steps, if you are going to answer, you cannot answer. So read the whole question and you should pick up the other key points for this. And as we expected, there is elevated JVP. JVP elevation is a feature of right heart failure, right? And there are prominent A and V waves. Note it down. There are prominent A and V waves. We'll see what is that. An auscultation of the heart reveals a hollow systolic murmur at the left lower sternal border, and it's increasing with inspiration. Actually, the key point for this question is this. There is a pansystolic murmur and that is increasing on inspiration. So any murmur increasing on inspiration means it's a right-sided murmur. Any murmur better heard in expiration means it's a left-sided murmur. So what is a right-sided murmur which is pansystolic? It's nothing but tricuspid regurgitation, right? Very simple. The answer is tricuspid regurgitation. So the other options are also not fitting in this. In case of atrial fibrillation, he can present with heart failure, but it's both left and right heart failure. And if you look at the pulse will be irregular, and if you look at the JVP, there will be absent A waves. And he has given that there are prominent A waves. So you are excluding that. And coming to pulmonary embolism, you don't hear any murmurs in pulmonary embolism, and there is no prominent V wave in pulmonary embolism, maybe prominent A wave. And coming to cardiac tamponade, in cardiac tamponade, the X descent is prominent and the Y descent is absent. There is nothing to do anything with A and V waves. So in the question, he's speaking about the positive waves. Most probably it's endocardial or myocardial disorders. And if he's speaking about the negative waves, it's most probably pericardial disorders. So this point about JVP, just remember, because every time you cannot apply, okay, A wave, absent in which condition, present in which condition, you cannot remember all those things in the exam. So a simple cheat code here is prominent positive waves. He is speaking about some myocardium or endocardial disorder. And anything about negative waves, that is about pericardial disorder. It can be your cardiac tamponade or constrictive pericarditis, anything. So this is a simple cheat code you can remember. So what is the answer? It is tricuspid regurgitation. So this case is a case of chronic obstructive pulmonary disease, because of which this patient is having chronic pulmonary arterial hypertension probably. Because of that, maybe he would have developed tricuspid regurgitation. So we'll see the other things about JVP. And one more thing you have to note down in the question is there are prominent A and V waves with absent X descent in your tricuspid regurgitation. Very important. Tricuspid regurgitation, you call it as a AV wave. Why? Because there are prominent A and V waves with absent X descent. I'll show you how it will be seen also, because sometimes they'll give you the picture. Prominent A and V wave with absent X descent. Very important. So tricuspid regurgitation, your cardiac tamponade and constrictive pericarditis, JVP, it should be on your tips, and you should also know how the diagram of JVP will look like. So before seeing the abnormal JVPs, let's see the normal JVP. So normal JVP, the two prominent positive waves are your A and V wave, and the two prominent negative waves are your X and Y wave. So I was speaking right, I was telling you that positive waves, any abnormality, it's endomyocardial disorder. Negative waves, any abnormality, it's pericardial disorder. And in your tricuspid regurgitation, there is a V wave without X descent. So how can we draw that? There is a A wave and directly there is a V wave and Y descent. A wave, V wave, Y descent. This is how a JVP wave in tricuspid regurgitation will look like. We call it as AV wave. Got me? Next, how are the waves in cardiac tamponade and constrictive pericarditis? I told you it's important, right? In cardiac tamponade, we already discussed there is a prominent X descent, but Y descent is absent. And in constrictive pericarditis, the X and Y descents are prominent. Tamponade, constrictive pericarditis, X descent is prominent, even your Y descent is prominent. So because of the prominent X and Y descent, it is looking like W, right? So that W pattern of JVP in constrictive pericarditis, you call it as Friedreich's sign. So now you know every important point of JVP, right? So with this, we will move on to the next question. The same way, we'll pick up the key points and answer this question. So here it's a elderly man. He came with complaints of exertional dyspnea and chest pain. Remember, these symptoms are very important. Each valvular disorder will have a specific symptom subset. Based on the symptoms only and the duration only, you can differentiate, okay, this can be this valve involvement. That important is the symptom history in valvular diseases. And on auscultation, there is a harsh crescendo-decrescendo murmur heard at the right upper sternal border. And it's radiating to carotids. Every point is important. And the murmur is louder when the patient is asked to squat. So while squatting, afterload has increased and the murmur has increased, and it's decreasing in intensity when the patient stands or performs the Valsalva maneuver. So whenever the patient is standing or he is performing the Valsalva maneuver, what will happen to the preload? The preload will decrease. So almost in the heart, any murmur, if the preload and afterload is increasing, the flow through the cardiac chambers will increase and any murmur will exaggerate. So whenever you are decreasing the preload and afterload, the flow through the cardiac chambers is decreasing and any murmur will decrease. So if you decrease the preload afterload, murmur intensity will decrease. If you increase the preload and afterload, murmur intensity will increase. This is true for all the valvular diseases except two conditions. So for everything there are exceptions, right? The only two exceptions is HOCM, hypertrophic obstructive cardiomyopathy, and your mitral valve prolapse. So these go in opposite direction. So Valsalva will decrease the preload. So any murmur, the intensity will decrease. But it's opposite in HOCM. In HOCM and mitral valve prolapse, Valsalva will increase the intensity of the murmur, and this is very important. And they will be asking in, they will be jumbling it in asking in different ways. But the ultimate answer is Valsalva. Any murmur intensity will decrease. In HOCM and mitral valve prolapse, it will increase. You should remember this because this is the most important point. Okay, we discussed about that, but what is this? Elderly male with chest pain and he's having a systolic murmur radiating to carotids. What is this? It is a simple aortic stenosis. So before saying it's aortic stenosis, let's see why not other options. Why it's not mitral stenosis? So mitral stenosis most common cause is rheumatic heart disease, most commonly seen in females. Here it's a male. Just based on that I cannot exclude. But what is a murmur in mitral stenosis? It is a diastolic murmur. And will it radiate? No. Here it's a systolic murmur radiating to carotids. What is the murmur of hypertrophic obstructive cardiomyopathy? It's same like AS, but it's not radiating. This is also ejection systolic murmur, but it's not radiating. Aortic stenosis is also ejection systolic murmur. The exact murmur we have seen here is the ejection systolic murmur, and it will radiate to carotids. And coming to aortic regurgitation, what is the type of murmur? It's a diastolic, early diastolic crescendo murmur, decrescendo murmur. So this is S1, this is S2. Mitral stenosis, first there is opening snap followed by a murmur. And for that murmur, there is a pre-systolic accentuation. You should know the pictures also. And aortic stenosis, it is a crescendo decrescendo ejection systolic murmur. Coming to aortic regurgitation, it is early diastolic decrescendo murmur. You got me right? And why there is chest pain? So shortness of breath, chest pain and syncope are the typical clinical features of aortic stenosis because the carotid arteries are arising from aortic sinus. So when there is aortic stenosis, not enough blood going to aortic sinus, not enough blood going to carotid arteries. So there will be ischemia. They will be having ischemic pain. So chest pain, angina will be there. And why there is syncope? When there is aortic stenosis, the blood through the aorta is decreased and the blood flow to the brain is decreased. That is why there is syncope. So whenever there is left heart failure, there can be shortness of breath. So shortness of breath, your syncope and your, chest pain is typical. Angina, syncope and dyspnea. This is the typical presentation of your aortic stenosis. Never forget that. Whereas your mitral stenosis, they will have prolonged history. Since 5 years, I am having shortness of breath, I am having palpitations. Sorry, no palpitations in stenosis. In regurgitations, you will have palpitations. So mitral stenosis, they'll be having shortness of breath since years, almost 5 years. After 5 years, they will decompensate. Whereas aortic, they'll be having less history, 1 to 2 years only, they'll be decompensating. So what is the answer? It is aortic stenosis. So the same thing we have discussed, aortic stenosis will radiate to carotids. HOCM is also a same murmur, but it will not radiate. So these are the pictures I just drew for you. Aortic stenosis is a crescendo decrescendo murmur. Mitral regurgitation is a pansystolic murmur. Aortic regurgitation is a decrescendo early diastolic murmur. Mitral stenosis, there is an opening snap followed by a mid diastolic murmur with presystolic accentuation. Whereas PDA, patent ductus arteriosus, it's a continuous murmur. So not only the naming, you should know the picture also. In exam, they can give you the picture also. So this is about the valvular disease. So valvular disease, you should know. Rather than treatment, he will ask you the clinical signs in valvular disease. So that should be on your tips. Coming to the next question, it's a 50-year-old male. He came to the emergency department with complaints of palpitations, dizziness and chest discomfort. So whenever a patient complaining of palpitations, what do you think? It's very important because one of the clue in the exam for you is palpitation. Not only in the exam, even in the patient, it's the clue. So palpitations means two things are happening. Either it's a arrhythmia or it's a volume overload. So volume overload you will be seeing in regurgitation murmurs. So any patient complaining of palpitations, so even I will have palpitations. If you ask me to climb 10 floors by steps, maybe I'll have palpitations. But that is physiological. After exercise, during anxiety, anybody will get palpitations, but this is a pathological palpitation. One will have the feeling of one's own heartbeat and it's not that fine. It is a abnormal feeling of one's own heartbeat. And the causes are arrhythmia and regurgitation. So in this patient is having palpitations. Only two things, he'll be having arrhythmia or a volume overload. How do you examine? See the pulse, auscultate. So if you do these both things, you will understand whether he's going through any arrhythmia or volume overload. Take an ECG. You will better read the arrhythmia. And this patient is having hypertension. So this is a typical history. Elderly male with hypertension. And they have taken the ECG. That is what we are discussing, right? And what is the ECG showing? In exam, you have to read the ECGs. What ECGs they can ask? The important arrhythmias, tachybrady arrhythmias and your MIs. And some named waves they can ask and the signs of pericarditis. Those things they can ask as an ECG. So keep seeing those ECGs. So what do you find in this ECG? So the first prominent thing I can see is the heart rate is irregular. If you look at the RR intervals, they are not regular. They are irregular. And they are irregularly irregular. So it's irregularly irregular rhythm. What is the next thing you can see? Can you see a P wave? So what is the best lead to see the P wave? It is second lead and V1. If you go into details of the second lead, no, I cannot see a P wave. V1 also there is no P wave. Absent P wave. And any ECG, the most important thing is your QRS complex, especially tachyarrhythmias based on the QRS complex. If it's wide, then it's ventricular origin. If it's narrow, then it's supraventricular origin. You got me right here. The QRS complexes is narrow, so it is supraventricular origin. What is narrow QRS complex? Less than 0.12 seconds. So less than 3 small boxes. So supraventricular origin arrhythmia, that is, the origin is from the atria. So an arrhythmia coming from atria with absent P waves and irregular rhythm. What is that? It's nothing but your atrial fibrillation. The answer is atrial fibrillation. So let's rule out other things. Why it's not atrial flutter? So I used to be so much confused between flutter and fibrillation. So to know the difference between flutter and fibrillation, just keep ECG aside and understand the pathophysiology first. In atrial fibrillation, in the left atria, there are multiple ectopics. So one ectopic, it will contract. One sinus node, it will contract. But the electric charges are coming from multiple ectopics. So your atria won't contract, it will fibrillate. So it is multiple micro reentrant ectopics. So they are multiple and micro reentrant. So your atria is fibrillating. It's not contracting, it's fibrillating. So when it's fibrillating, there is blood which is being pooled, and which is pooled for a constant time, it will form a thrombus. That is why there is left atrial thrombus, and that thrombus will go into left ventricle and in your systemic circulation. So more chances of thromboembolism in AF. This is the cause. Whereas your flutter is a single ectopic and it's macro reentrant. So your atria is going to contract. So this difference you should know. Atrial flutter is a single ectopic and atrial fibrillation are multiple ectopics. So when there are multiple ectopics in the atrial fibrillation, there is a fibrillation. One contraction, P wave. Multiple fibrillations, fibrillatory wave. And you will get a QRS complex somewhere. Among these fibrillations, any one can cross the AVE node and it will come to ventricle, and ventricle will contract and there is QRS complex. Again, fibrillatory wave, QRS complex. So fibrillatory wave with absent P wave and irregular QRS complex is what your atrial fibrillation. But in atrial flutter, there is a single ectopic, and that ectopic will produce P waves. If atria contracts, P waves. And among those contractions, one will be transmitted to the ventricle. So you will get a QRS complex. Again, ectopics. So I think now you got the difference between atrial flutter. Sometimes if the AV block is variable, there can be irregular rhythm in atrial flutter also. But the difference is in atrial fibrillation, the P wave is absent but there are fibrillatory waves. And in atrial flutter, there are P waves of same morphology. That is why they are seen as sawtooth pattern. So now you know how to differentiate atrial flutter versus fibrillation. Clinically, sometimes flutter and fibrillation will coexist. Flutter can change into fibrillation. Fibrillation can change into flutter clinically. But in exam, they won't confuse you. The ECG is either flutter or fibrillation. Most of the times, it's fibrillation only. And they can give you flutter only to confuse you. This is clear, right? Let's see the ECG so that it will be easy for you. So if you look at the first ECG pattern, there are irregular narrow QRS complexes with no P wave. And some here, second one you have to see. See the second one, irregular QRS complexes which are narrow with absent P waves, and here and there are fibrillatory waves. So here are the fibrillatory waves. This is atrial fibrillation. And if you look at the third ECG, there are beautiful P waves of same morphology and comes a QRS complex. So sawtooth P waves. This is atrial flutter. Now I think you can be able to differentiate fibrillation versus flutter. So the treatment, the management can be almost similar, but AF, it's more morbid. Now coming to ventricular tachycardia, the origin of this tachycardia is ventricular. So there is an ectopic in the ventricle. So when there is an ectopic in the ventricle and from that the ventricle is contracting, there is broad QRS complex. And if it's a sinus tachycardia, there is a beautiful P wave, beautiful QRS, beautiful T wave. Everything will be there, but there is tachycardia, increased rate in sinus tachycardia. But in that ECG, there are no P waves, so it's not sinus tachycardia. You got me? And this is regular. So the answer is atrial fibrillation. So the same thing is given in this. We have seen two ECG patterns. Let's see the other ECG patterns. Your tachyarrhythmias are very important, especially your supraventricular. Most of the times they'll be asking supraventricular tachycardias. In that your PSVT and AF are very important. You should know the ECG, how to diagnose, what is the JVP pattern in AF. Sometimes they can correlate, and what is the management of AF, you should know. Okay, where are we? Coming to the first ECG. So this is a bit confusing, right? Here also there is irregular pattern. And there is narrow QRS. But if you see the P waves, here the morphology of P wave is different. The morphology of P wave is different. The morphology of P wave is different. So there are different morphologies of P waves. That is why it is called multifocal atrial tachycardia. And it's most commonly seen in COPD. In this condition, you can give beta blockers or calcium channel blockers. But in a case of COPD with multifocal atrial tachycardia, while choosing a beta blocker, you should be careful because beta blockers are bronchoconstriction. They will cause bronchoconstriction. So better choose cardioselective beta blockers or go for calcium channel blockers in a case of COPD with multifocal atrial tachycardia. That's a clinical condition. Coming to the fourth ECG, I can see narrow complex QRS and there is tachycardia, but there is only T wave. P wave is absent. Why P wave is absent? P wave is submerged under the QRS complex. Because of tachycardia, there is no place for P wave to be seen here. No P wave. Narrow complex QRS tachycardia. What is this? This is your supraventricular tachycardia. Fine. Now you know everything about supraventricular tachycardias, how to differentiate. So I want to show you a few other things. So if you look at the first ECG pattern, after QRS, after ending of the S wave, there is a decline. That is called epsilon wave, and you see that in arrhythmogenic RV dysplasia. So it is a type of cardiomyopathy where your right heart, the muscle, the cardiac muscle is replaced by fat tissue. That is arrhythmogenic right ventricular dysplasia, and these patients most of the times will die of sudden cardiac arrest, and in ECG there is a epsilon wave, that is aberrations in the baseline of the ECG at the end of the S wave. And one more thing is in WPW syndrome, your Wolff-Parkinson-White syndrome, what is the ECG pattern? So your Wolff-Parkinson-White syndrome is a pre-excitation syndrome. So because it's a pre-excitation syndrome, your PR interval is short and there is a delta wave. If you look here, it's looking like a delta. So short PR interval with delta wave is the ECG clinical sign for Wolff-Parkinson disease. So these questions they can ask you in the exam. directly by giving the question or as an explanation in the question. And few more ECG important points. Coming to the P wave, what is the best ECG lead to look for P wave? So when I asked you to look at a P wave in the ECG, which leads you will be searching? So you should look at lead 2 and lead V1. These are the best leads to look for and your P wave. So how a P wave will look in lead 2? It's a single positive wave. How a P wave will look like in V1? It's a biphasic wave. In V1, your P wave is biphasic. So that is the normal P wave. So coming to, this is normal. What will happen in right atrial enlargement? In right atrial enlargement, there are tall peaked P waves. So your P wave are tall peaked. And in the biphasic part, see biphasic part, the positive part is right atrium, the negative part is left atrium. So the positive part will increase. What happens in left atrial enlargement? There is broad P wave which is bifid P wave in lead 2, whereas in lead V1 the negative component will increase. So this is about the P wave. With this question, we have learned the basic supraventricular tachycardias and the important ECG waves. So we'll be back after 5 minutes.